We're very excited about our speaker. Michael HASSELBERG is a clinician researcher extraordinaire, healthcare entrepreneur from the University of Rochester. He, like we, traveled to New Mexico to look at the ECHO model and decided that they wanted to take it back and see how it would fit best amongst the different kinds of things they were trying to do in their healthcare setting. And is evaluating that, and is one of the locations in the country that actually have good data for demonstrating what ECHO with other approaches can be used to attack healthcare costs and reduce unnecessary expenses. So we're very excited about Michael, and he will come out and speak, and then we'll have a few minutes. And again, if you have time tomorrow, we have some time this afternoon, and tomorrow we have an open house at ECHO in the Nighthorse Campbell building, so we invite you to come over there as well if you have other questions, and don't hesitate to let us know. But thank you, and thank you for being here.
Thanks, Fred. I can tell you what, this is an intimidating room to present in. This is a first for me. I don't even know where to kind of put my eyes, but I want to thank you guys for having me out here to Colorado, and the weather is beautiful. Where I've been told by my wife we're getting dumped on in snow back in Rochester, New York, and there's no snow, and it's sunny here in Colorado, so that works out well. Before I begin, I have some acknowledgments. I have a lot of grant funders for my work with telemedicine and Project ECHO, so I just wanted to kind of acknowledge those folks. What I really want to do today, the clicker is, yeah. Perfect. I want to tell you about my community, where I'm from. So this is a picture of Rochester, New York. When people think of New York State, they immediately think of New York City. We are nowhere near New York City. We are in Western New York, upstate New York, and we're a city and that has an catchment area of about 13 counties, and within those 13 counties, there's about 1.5 million people. So when we kind of break down this 1.5 million people, we estimate that almost 300,000 of these individuals have behavioral health diagnoses or psychiatric disorders. And as a clinician, this is kind of my area of expertise and specialty area. The great thing about Rochester is the University of Rochester. You know, this community has one of only about 120 standalone academic medical centers left in the country. And at the University of Rochester, we have a very robust department of psychiatry where we have, you know, residents, we have fellows, we have a psychiatric nurse practitioner program. We do psychiatric care in pediatrics all the way up through geriatrics and in forensics. However, in my community and in my region, there are counties, like Steuben County, Schuyler County, Livingston County, and Allegheny County, where in these counties, there is not a single psychiatrist or a single psychiatric nurse practitioner for the entire county. So then when we kind of look at the greater Rochester region, and we would call this the Finger Lakes region of New York State, Rochester being up in Monroe County, where you see that kind of little U of R, and again, you know, the 13, 14 counties surrounding us, we know that our region of the state has a much higher psychiatric comorbidity than the rest of the state. Also, in our region of the state, suicide is the 5th leading cause of premature mortality. When we look at the counties surrounding Rochester, the counties in red, they really have no behavioral health services at all. The counties in blue, they do have behavioral health services, but there are still subsets within those counties of patients that aren't able to get the care that they require and that they deserve. when we kind of look at the hospital system and systems within my region of New York State, there are 23 acute care hospitals in this Finger Lakes region. 2 of these hospitals have psychiatric emergency departments, and they're up closer to the urban Rochester area. Outside of that, there are 7 other hospitals that have inpatient psychiatric beds for about a total of 250 psychiatric beds for this entire community. When we did a community needs assessment, we found that one of the top 5 diagnostic clusters for ED, avoidable ED presentations in our region, psychiatric illness was in that top 5 and drivers of that. And actually, specifically was the highest of all disease states for admissions from the ED. So that kind of brings me to my story. So I joined faculty at the University of Rochester about 5 years ago. As a clinician, I'm a psychiatric nurse practitioner. I specialize in geriatric psychiatry. I have a PhD in health practice research. Alzheimer's disease was my area of interest and my love. I was actually a clinical trialist. I was going to be that guy that was going to find that new drug that was going to cure Alzheimer's disease. I also saw patients, Alzheimer's patients, in our outpatient memory care program. And I had an 8-month wait list to get in to see me at that time. So I knew there was a need. So when I joined faculty, it was my chair who said, you know, the work you're doing in Alzheimer's disease, that's great and all, but I'm not really interested in that. If I let you join faculty here in the School of Medicine, I want you to develop a telemedicine infrastructure for our department. At that time, we were doing no telemedicine work out of our Department of Psychiatry, and at the university, we really weren't doing any telemedicine work. I knew nothing about telemedicine, but I really wanted to join faculty, so I said, great, I'll develop telemedicine for your department. So that's what I did, joined faculty, and something I was good at was writing grants. And so I wrote a grant to the New York State Health Foundation to do a more traditional telemedicine model. And I was going to start it in geriatric psychiatry because that's what I knew, and I knew that there was a need in my community. So the grant that I wrote was your more typical telemedicine where we have the geriatric psychiatrist at the academic medical center. The older adult patient presents to the primary care practice. We would virtually assess that patient in the primary care practice and essentially hand that patient off to the primary care doctor. The New York State Health Foundation said to me, we love the idea of integrating behavioral health into primary care, but we're not so excited about traditional telemedicine. Telemedicine had been around for, you know, almost 50 years and, you know, really hadn't taken off. And they said, you know, we'll fund you to integrate behavioral health into primary care, but we'll only fund you if you do this ECHO model. And this foundation had actually gone down to the University of New Mexico and had learned about ECHO. And at that time, ECHO had not come to New York State, and they wanted to be the foundation that brought ECHO to New York State. So again, they said to you, we'll fund you, but only if you do this integration using ECHO. I knew nothing about ECHO, but wanted the money and said, great, I'll do ECHO. So I went down to the University of New Mexico to get immersed in this model and to get trained in this model. And essentially, this is a model, for those of you who aren't familiar with it, you know, started about 15 years ago in hepatitis C care. And it's based on this concept that at academic medical centers, that is where you have the wealth of subspecialty expertise. And how do you demonopolize that expertise? And how do you get that out to the generalist providers? Essentially, primary care physicians, long-term care physicians, and how do you help train them to develop the knowledge base and have the capacity and decision-making support to better manage these specialized patients within their own communities, within their own practices. Hence, you know, you have a broader patient reach, where in telemedicine, yes, I can see a patient at great distances, but I'm only touching one patient on the other end. This is the idea, if I can train the generalist providers, now I'm touching lots of patients. So it's this kind of one-to-many model. So when I went to New Mexico, I'm gonna be honest with you, I was very pessimistic about this model for a couple of reasons. I'm a researcher. We're taught that, you get evidence. Once you get evidence on a model, then you disseminate this model. When I went to New Mexico, there was no evidence to support this model of being of any benefit. There was one single study in the New England Journal of Medicine in Hep C, but outside of that, nothing had been published yet. However, this was a model that was disseminated across 25 different states. It was in 10 different countries. I just didn't understand that. And I said, how come no one's evaluating this thing? The other thing was, when I came back to New York State, I was pessimistic that this was going to work in my state, for a couple of different reasons. The first major reason is in New York State, at that time, the majority of reimbursement in our state was fee for service, where essentially primary care docs, they get paid by how many patients they can crank out in an hour. And I said to myself, how am I going to convince these really busy primary care doctors to essentially leave their reimbursement mechanism to come to an education program, once a week, once every 2 weeks? And oh yeah, I was going to train them to not only become experts in behavioral health, but geriatric behavioral health, where these patients are complex, they're time consuming, and the reimbursement for these patients are horrible. I said, no one in their right mind is going to want to sign up for this thing. But I was actually pleasantly surprised. So we launched our first echo in New York State in 2014, and we launched it in geriatric mental health for primary care. And we had over 75 primary care practices and over half of the counties across our state that participated in this echo program. We trained over 500 primary care providers in geriatric behavioral health, and we averaged about 15 providers per echo clinic. And of course, in this model, you give out CME credits, and we gave out about 250 CME credits. The one thing that I wanted to make sure that I did when we launched this model was to do a good, robust evaluation of this model. And so we took a mixed methods approach. Most of the echo research at that time had been focused on, provider satisfaction, self-efficacy. We did that. We did qualitative interviews. But the other thing that I wanted to do is, I wanted this model to be sustainable in my state once the grant funding ran out. So I quickly, as soon as I came back to New York State, reached out to our large commercial insurer in our region, Excellus, Blue Cross, and Blue Shield. And I said to them, hey, I'm going to be launching this new model in our region and in our state. Would this be something you guys would be interested in learning more about? And they said yes. And then I asked them, would you partner with us around evaluation of this model? And they said, yeah, we would be interested in this. The one thing that I did know, however, was that I was concerned that if the University of Rochester and my team was the ones to develop this model in New York State, implement this model in New York State, and evaluate this model in New York State, that there would be considered some bias to that when I go back to the insurer and say, now I want you to pay for this. So we actually elected to farm out our claims evaluation to the New York Academy of Medicine. And for that bias reason, but also at the same time, Excellus was not going to give us access to their paid out claims, because essentially if they gave the University of Rochester access to the paid out claims, we could essentially figure out what our competitors are getting paid at. And we give us leveraging, negotiation leverage with Excellus. So what we did was we partnered with the New York Academy of Medicine in terms of telling them the type of outcomes we wanted to look at, the protocol that we wanted to do to evaluate this thing. The claims data was sent to the New York Academy of Medicine. The third party, they did the evaluation and then sent the results back to us to interpret. So we identified 35 of those 75 primary care practices to actually have Excellus beneficiaries within those practices. And what we were really interested in were older adult patients, 65 and older, with psychiatric comorbidities. And we identified psychiatric comorbidities by the CPT claims, but also understanding that primary care providers tend to underdiagnose psychiatric illness. We use psychotropic medications that these patients were on as a proximal indicator of a psychiatric illness. And we didn't have a lot of money to do evaluations, so we were only able to do kind of a pre-post, 6 months pre echo, 6 months post echo. And again, we wanted to look at all of the claims data coming out of the primary care practices that participated in echoes. So all of the patients served by that practice. We really wanted to do some propensity controlled matching, but unfortunately, because I had such a wide dispersed network of spoke sites that participated in this specific echo program, we had trouble identifying controlled matches. So something that I will discuss later of learning from this pilot work, and we adapted it for our next evaluation. So we had about 30,000 Excellis beneficiaries that we looked at for this evaluation. And again, primary psychiatric diagnoses, dementia diagnoses were included in this. And the outcomes of interest that we were interested in were high utilization, high cost outcomes. So inpatient visits, outpatient visits, ER visits, high cost psychotropic medication use. And what we had found was the primary care practices that participated in ECHO, we almost reached statistical significance in regards to reduction of ER utilization of Excellis beneficiaries 65 and older that have psychiatric comorbidities. When we looked at the associated cost data to this utilization, we actually did reach statistical significance for reduction in ER-associated costs. I want people to interpret this data with caution because we were not able to control for anything. So it's hard for me to say with confidence that it was the echo intervention that actually drove down this utilization and drove down this cost. But that being said, this was an encouraging finding, an encouraging trend. And it was encouraging for us because it gave us an opportunity to really identify how to develop protocols, to look at large data sets of claims data, and to really start thinking about how would you look at the return on investment of this model. And at that point in time, nobody had yet done anything like this with ECHO. So I think the really interesting data that we received was our qualitative interview data. So like most ECHO qualitative evaluations, the providers, they really enjoy ECHO. They felt more job satisfaction, more efficacious. They felt like when they implemented the specialist recommendations, they saw a patient level improvement. Timing, of course, was, dedicating time to go to the ECHO sessions was a big barrier to ECHO. But really two major themes came out of this qualitative evaluation. The first major theme was that these primary care providers, despite what epidemiology data tells us, they perceive that only a small subset of their caseload was of geriatric age. So they said, we love this ECHO, but we wish we could present younger patients to these ECHO clinics. I took that to heart, wrote another grant which was funded, and we started a general psychiatry ECHO up for primary care where they could present patients across the lifespan. The other thing that we learned was that in the rural counties of New York State, it's essentially the primary care docs who are the hospitalists in the nursing homes. And they said this geriatric mental health ECHO would be perfect for the nursing home setting. I took that to heart, wrote another grant which was funded, and we took our geriatric mental health ECHO out of primary care and we put it into the nursing home long-term care setting. So we launched our ECHO and geriatric mental health for nursing homes in December of 2015. And in my perception, this is probably our most successful ECHO program that we're running out of the university. We've trained over 3,000 nursing home clinicians in geriatric mental health and dementia care. You know, we've given out, you know, over to 1,200 CME surveys, and we average about 45 nursing home clinicians per echo session. We actually, in the Finger Lakes region, which I discussed, there are 63 nursing homes in that region. 61 of those 63 nursing homes participate in this echo. We actually have 2 cohorts of nursing homes that run on opposite weeks for this specific echo. Now, this evaluation it was a little bit easier for us to do. We're not dealing with claims data. We're still using a mixed methods design. We're doing qualitative interviews with participants. But you know, we were really focused on the MDS quality indicators, which these nursing homes have to report back to CMS. They're already reporting these indicators to CMS on a quarterly basis. And as we move from volume-based care to value-based care, it's going to be these quality metrics that these nursing homes are going to be either incentivized or penalized around meeting. So we specifically, you know, wanted our evaluation to look at impact on these quality indicators, but we also developed our didactic curriculum around teaching these nursing homes about best practices around meeting these quality metrics. And again, we were interested in the behavioral health quality metrics, which include depression symptoms, antipsychotic use, anxiolytic or benzodiazepine use, restraint, falls. Those were the quality indicators that we were interested in. And because we had only started this specific echo program in the Finger Lakes region, we had, you know, a good almost 590 nursing homes across New York State that we were able to do some propensity controlled matching to compare whether or not the echo intervention is actually making a difference for the nursing homes that are participating. So these are very preliminary findings. This is an ongoing project, but what we're finding thus far, and the problem with the MDS quality indicator data is there's a 6-month lag time for this to be publicly available, so we're a little bit kind of behind. But this is, again, this is a pre-post evaluation of these practices, and we are seeing a significant trend down. Specifically in depression symptoms, that's probably the most prominent. Then short stay, antipsychotic use, and benzodiazepine use is where we're seeing really the most benefits. And that trend down is much sharper in the nursing homes that are participating in echo compared to the nursing homes in the state that are not participating in echo. When we look at the patient cases that are presented to echo and we follow up to see how those patients are doing, you know, we're finding that about 80% have had target improvement once the specialist recommendations have been made, and none of the patients that we're aware of thus far that have been presented to echo for an initial case presentation have been hospitalized since that presentation. And like, again, all echo programs thus far, folks tend to enjoy it, and the CME survey data is also indicating that. This great work that we've been doing with echo in nursing homes in the Finger Lakes region has actually caught the eye of some of our state government agencies, specifically our Office of Mental Health, where in our state, like most states in this country, our state psychiatric facilities are downsizing. They're closing down units, and a lot of these patients who have been institutionalized for 20 years have, you know, kind of aged out, and now they require nursing home level of care. But the state psychiatric facilities are having a significant time discharging these patients to the nursing homes. And the nursing homes are either A, refusing to take these patients, or when these patients arrive to the nursing home, within a week, the nursing homes are sending these patients back to the state psychiatric facilities. So the Office of Mental Health looked to us and they said, hey, we want to contract with you to essentially replicate your nursing home echo up in the Finger Lakes region for the New York City, Long Island region, because that was where the area of the state they were having the most difficulty discharging patients from the state psychiatric facilities into nursing homes. And so we launched our echo for our Office of Mental Health in Nursing Homes in June of 2017. And this echo is very interesting because we have both the nursing homes and the state psychiatric facilities who attend this echo session. So we actually get to really just talk about kind of care transitions from the state facility into the nursing home facility. We're actually doing a lot of teaching to the state psychiatric facilities about nursing home culture, and then we're teaching the nursing homes about behavioral health and dementia care. And the Office of Mental Health is already looking to contract with us to expand this specific ECHO program into the Capital Region and the Southern Tier region of New York State for those nursing homes. So as I said, from our pilot work, one of the things that we learned was that the primary care providers really wanted a general psychiatry echo, which we did launch, and we started in 2016. And this echo has also been quite successful. We've trained a little bit over, almost 800 primary care providers in general psychiatry. We're averaging about 21 providers per the general psychiatry echo clinics. But this echo, I wanted to address the limitations in the evaluation to our pilot work. So I was very strategic around how we were going to proceed with the general psychiatry echo. The first thing I did was I narrowed the spoke sites down. If you can remember our geriatric mental health echo in primary care, we had 75 primary care practices across most of the state. I said, that was too dispersed. I didn't have enough control of the data. So I closed it down to just primary care practices in our university's accountable care organization, where then I would have better control of the data and have an opportunity to identify primary care practices that did not have any other behavioral health integration interventions happening in that practice, and would allow me to do some propensity controlled matching of practices that did not participate in the ECHO program. The other thing was that in our primary care ECHO in geriatric mental health, it was really hard for the physicians and nurse practitioners and physician assistants, essentially the providers, to attend the ECHO sessions. Not surprising given how busy they are. So what I specifically wanted to do for this ECHO was to target nurse care managers integrated into these primary care practices. When people think about kind of collaborative care models for behavioral health, it's really focused on the care management model. The nurse care managers, they're not getting reimbursed for what they're doing. So, I don't have to worry about the loss of revenue. So they're able to kind of come and participate in these ECHO sessions. But really, they're the direct liaison between the patient and the primary care doctor. So I felt that that was the right target audience to focus on. The other thing was that we widened the patient profile for really adults 18 and older. We did a little bit longer out pre-post comparison, up to a year for this specific echo. So we also did a little bit more robust statistical analysis. We did a difference in differences model, really with the hopes to kind of isolate the echo intervention. This is really the closest that we could get to doing a more randomized type control trial without really doing a randomized control trial, and really be able to do it in real world practice. And again, we did propensity matching for the practices and the patients. And then we've also focused on the same kind of utilization and cost outcomes. So, the first thing we did was we looked at, really all Excellus insurance products. And what we had found was a really kind of strong statistical significant reduction in ED utilization, outpatient behavioral health utilization, but we did not see the cost. That did not reach statistical significance when we looked across all payer products. And we were wondering, why? What's the issue? We have such a strong reduction in utilization, but the cost data just doesn't seem to follow. The concern was that there was probably too much variability between the different product lines. So we actually asked Excelis to rerun the analysis per product line to see, where we could find, where if we were saving costs, where was this cost being saved? And what was really exciting was we found it was the Medicaid population, that it was their safety net products that we found reduction in costs. And the reduction in costs was really kind of localized to emergency room costs. Exciting finding for us. So this is actually the first time I've presented this data. We have not published this yet. The effect size for the cost is small. We don't have a really good understanding of what that cost savings actually means, or what it looks like, or how much money we're saving. But for us, it was just exciting to see that, yes, we were able to save costs related to ED presentations for the safety net population, specifically around behavioral health patients. And there really hasn't been a whole lot of interventions to date that have been able to show that. So some of the challenges that we have in New York State around ECHO are similar to the challenges that most of the country has. There is no really long-term funding mechanism for the ECHO infrastructure. The other problem with ECHO, specifically in a volume-based reimbursement mechanism, is that if we actually are reducing ED utilization for a big academic medical center like the University of Rochester, that's actually a loss of revenue to us. So we kind of have misaligned incentives attached to what ECHO may be doing. The other problem is if you disseminate ECHO too quickly, too widespread, eventually you're going to burn out your spoke sites to ECHO. Primary care doctors can only take so many ECHO sessions. Same thing for nursing home providers. So, we have to be very strategic about what ECHOs we offer in what geographic regions so we don't burn out these providers. Some of the opportunities that are happening in New York State is this health reform that's happening across the country, more localized also to our state, where we're moving from volume-based reimbursement to value-based reimbursement, where it's no longer are we going to be reimbursed by how many patients we can see, but actually the quality of care that we're providing to larger populations of patients. In New York State, we have two major Medicaid health reform initiatives that are happening. The first is the Delivery System Reform Incentive Payment Program. This was essentially CMS gave New York State $8 billion to kind of spread across the state to communities where essentially these communities kind of banded together to form what we call performing provider systems. These performing provider systems, you typically have a lead organization, typically the large health system in that community, but the performing provider system encompasses all providers, including primary care, long-term care, but it also includes transportation and housing. And essentially, what these performing provider systems were encouraged to do was to develop new systems of care where you typically don't get reimbursed for, specifically around reducing Medicaid rehospitalizations, with this idea that they wanted to reduce Medicaid, avoidable Medicaid hospitalizations by about 25% over this 5-year period of time. And each performing provider system could identify certain district projects that they wanted to participate in. Our performing provider system, the Finger Lakes performing provider system, picked about 10 different district projects, and a handful of those projects were very behavioral health focused, and I'll get a little bit more in depth to that in a second here. The second kind of health reform mechanism that's happening in New York State is the Vital Access Provider Program. So essentially, a lot of the critical access hospitals in our state that serve the Medicaid population are bankrupt and are losing money. So the state wanted to reinvest Medicaid dollars into these vital access provider organizations, typically small rural hospitals, so they can develop new ways of providing care to that community to help those hospitals stay financially viable. And again, still focus on reducing Medicaid program costs. So to tackle this health reform in our state, to me, ECHO was just not enough. that, you know, echo, I think, is an important piece to the puzzle, but I don't think that echo alone is going to move the dial on quality indicators and costs that we were hoping to get to. I think that we need a whole new system of care for behavioral health, with echo being one piece of that. So we've now developed kind of this larger delivery system for behavioral health services out into these rural communities, which includes echo and ongoing telementoring and capacity building. We do think that there needs to be some on-site psychiatric engagement. It probably not need to be by a high-cost provider like a psychiatrist or a psych nurse practitioner, but maybe a psychiatric social worker who can be on site and do some primary evaluations, crisis interventions, and care coordination. And then for those really high acuity patients that on-site social worker or nurse may be not able to manage, or echo alone cannot manage, we then bring our high-cost providers, the psychiatrists and psych MPs from the medical center, into those rural communities using telemedicine to evaluate those patients. So when we talk about this health reform and how we implemented this bigger delivery system into our region, the first real kind of main district project was this integration of behavioral health into community hospitals. So this is what really was happening in our region of the state. If you were a patient that had behavioral health symptoms, and if you presented to a small community rural hospital into their ED for help with these symptoms, what would these hospitals do? They would just transfer you, because they didn't have any psych providers there. So they would transfer you 90 miles away to Rochester, to the psychiatric emergency department, where then someone like myself would evaluate you and deem you to not need inpatient psychiatry admission. And then we would tell you, you need to drive back 90 miles back down to your community with really no coordination of behavioral health services and really kind of no care. And this was what was happening in our state. So as you can imagine, these patients just kept coming back to their community hospitals looking for care. So we integrated this kind of overarching model first into our rural community hospitals, emergency departments, and inpatient medical units. So this telepsychiatry echo psychiatric assessment officer model that we developed really has three major aims to it. Increase behavioral health access, increase the quality of care to these patients in those community hospitals, decrease kind of transfers out into other communities, and help these hospitals, you know, manage higher acuity patients within those settings. And the way we did this was we integrated a psychiatric assessment officer. Am I running out of time? Oh, got it. So we integrated a psychiatric assessment officer into these EDs, and this person's role, this was a nurse, did primary assessments on patients who presented it to the EDs. And they did kind of care coordination out for these patients, helped refer them to services within those communities. For patients that the psychiatric assessment officer felt may need inpatient admission, one of our providers at the University of Rochester would evaluate those patients in their ED in that community hospital and decide, you know, does this patient need psych admission or not? If they do, we would transfer them out to a hospital where there's a higher likelihood that they're actually going to be admitted. If we did not feel that they needed admission, we would work with the PAO to coordinate those services. And then on top of this, you know, we provide telementoring in two ways. Our psychiatric assessment officers meet with our medical director together as a group using the Zoom platform for kind of case presentations and discussions and reduce isolation. But we also have a hospital medicine echo with behavioral health presence on it that the psychiatric assessment officers and the hospitalists in these community hospitals attend on a biweekly basis. Our preliminary results thus far are looking pretty good. You know, about 70 to 80% of these patients are being discharged to their community and being referred to community resources, with really only 20 to maybe 40% actually being transferred out of these communities for a higher level of care. And remember, all of these patients were being transferred out before this program was embedded in. The next kind of integration project, and I'll go through this quickly, was our nursing home integration project. Another district project all about how do we integrate behavioral health care into the nursing home setting. We already had ECHO up and going, but we wanted to layer these other interventions on top of ECHO. So we actually now use ECHO in those 60 nursing homes. So 30 of those 60 nursing homes participate in telepsychiatry on top of ECHO. ECHO serves as a triaging system. So if a case gets presented to ECHO that we feel is too complicated for ECHO alone to meet the needs of that patient, we will then offline identify that patient, schedule that patient to be seen by our geriatric psychiatrist or psych MP to do a direct provider to patient consultation. This telepsychiatry service is, 8:30 to 5, Monday through Friday service, staffed by psychiatrists and psychiatric nurse practitioners. The other thing that we do is, we send psychiatric nurses out to these nursing homes in person. These nurses do care planning with the nursing home staff. They do education. They also help the nursing home staff identify which patients would be appropriate to present to ECHO, which patients would be appropriate to refer to a telepsychiatry consultation. They also do kind of case registries where we ask the nursing homes to pull all of their patients on antipsychotic medications or all of their patients who screen positive on the PHQ-9 for depression, and we then coordinate the care for those patients. Our preliminary results thus far for that this is actually old data. We're up in almost 30 nursing homes now. In the first 7 months, we've had over 400 telepsychiatry consultations and about 120 on-site nurse engagement visits. The last integration thing I want to talk about, being cognizant of time, is the last kind of district project focusing on integration of behavioral health services into the primary care sector. There's a whole kind of array of digital interventions that can be done to integrate primary care or behavioral health into primary care. We're doing a handful of these at the University of Rochester. We have embedded into our primary care practices on-site nurse care managers, which we talked about. These nurse care managers get telementoring through our ECHO Psych program. We do universal depression screening and behavioral health screening through the patient-reported outcomes measurement information system. This is an NIH initiative called PROMISE. We actually have these PROMISE instruments embedded onto iPads, and when these patients check in for register at their primary care practice, they fill out these PROMISE instruments in the waiting room, and that data gets looped right back into the EHR. We have clinical dashboards set up. We have case registries which are compiled based off of this data. These patients are either presented to ECHO Psych or we do e-consults with these patients. And we're also in the process, because we don't have enough therapists to go around to integrate into all of these primary care practices. I have a grant right now where I'm developing a computerized cognitive behavioral therapy virtual reality platform, which we will then embed into our EHR that can be offered to these patients. When we talk about the Finger Lakes region and are these interventions making a difference? Well, our performing provider system just a few months ago presented the 3-year data results. So, we're finishing up year 3 of Disrupt's 5-year initiative. Again, the target was to decrease avoidable Medicaid hospitalizations by 25%. They've already achieved that. When they specifically looked at potentially preventable ED visits for behavioral health patients, that has decreased by 29% over the last 3 years. I can't claim that our interventions is the only thing that's driving this reduction, but we're really kind of the big systems of care that's happening in these disparate projects. So, selfishly, I want to say that, yeah, it is kind of the work that we're doing that is driving down these preventively Medicaid readmissions in these hospitals. Again, moving towards kind of data-driven, proactive behavioral health care. It gets back to that collection of promise data. You know, my concern has been with behavioral health for a long time is we do not do a good job, like our medical discipline colleagues, of collecting quantifiable data. We do a lot of subjective data. So it's hard for us to really know what of our interventions is actually working and for what types of patient populations is it working for. So I have a theory that our behavioral health system is all clogged up because we have probably low acuity patients being seen by the psychiatrist in person, and then those high acuity patients can't get in to be seen, and we need to kind of lower those patients to a lower level of care. And then we've got those high acuity patients who are going to the EDs or their primary care providers that need to get in to see the specialists. So in order to kind of declog the system, we need to collect data. I'm hoping that this data, this promised data collection on these iPads will allow us to develop this kind of robust data set where we can then start stratifying patients by risk severity. Then we can then know that patients with this type of risk severity tend to do best with this type of intervention. We can then develop care pathways on these clinical dashboards to triage patients to the right level of care at the right time at the right place. And again, this is something that we're building with our data science group. And we're collecting this data, and then we'll use machine learning analytics to, again, start triaging these patients. We've had a lot of recognition for all of our work that we've done from, you know, CMS, the Agency for Healthcare Research and Quality actually identified our echoes in behavioral health as being a policymaker impact case study. Oregon Health Authority actually brought me out as a consultant. They want to replicate our nursing home echo plus telepsychiatry for their entire state. And then in April, myself and I know Fred was invited to sit on a technical expert panel for the Department of Health and Human Services to talk to Congress about the applicability of technology-driven care in our health system. So sustainability, again, we're already looking at sustainability of these models in our region in New York State. Because of some of the early data that we're finding, our accountable care organization is now in contract negotiations with Excelis about building echo and telepsychiatry into some of their shared risk contracts. The Department of Health in New York State and the Office of Mental Health is starting to contract with the University of Rochester to pilot this model in other parts of the state with hopes that, again, we can collect more robust data where we can go back to the state Medicaid office and say, listen, this is the gold standard for behavioral health integration and you need to pay for this. So that was kind of my talk.